Yeah? I'm Betsy Schwartz. I'm Vice President of Public Education at the National Council for Behavioral Health, and it's my great honor to introduce our speaker and speakers this afternoon. I'm going to introduce Tyler, who will in turn introduce his colleagues. So as some of you, I suspect all of you already know from having read Tyler's bio, that he has spent much of his career advocating for the needs of the most vulnerable population and shares our ambition to make communities healthier. He has shaped health and sustainability initiatives in hundreds of communities and has an extensive background in population health and community well-being, and is a social entrepreneur, a title often given to people, but rarely in this kind of a context. He's a true advisor to philanthropists, health systems, government agencies, and many different kinds of partnerships. Tyler is the first chief executive of the Institute of Mental Health and Wellness, a new foundation that was created by a $100 million gift from Providence St. Joseph's Healthcare System, here mostly on the West Coast, where he helps advance innovative solutions for mental health and well-being. Tyler's compassion and tenacity will help our society change mental health in the U.S., as well as the perception that we all see every day and how people are diagnosed, treated, and accessing care. Now, he's here to share with us how to partner with community stakeholders, clinicians, payers, and to get upstream in holistically addressing the conditions of physical, mental, and spiritual mental health. Learn from him and a diverse set of leaders from the Institute and Providence St. Joseph's Health about how new systems can work with clinicians to deploy new service delivery models, community partners to improve access, and payers to incorporate mental health services into population-based health strategies. Please join me in welcoming Tyler.
Thank you for that lovely introduction. Good afternoon.
Good afternoon.
Very good to see you. A delight to be here, and we have a fabulous conversation about to ensue. So our theme today is on the power of partnership, and how do we work with health systems, health plans, community-based organizations, civic organizations. Essentially, how do we build a social movement of partnerships to deliver full spectrum integrated care? Not only to prevent and to treat, but to actually create healthier communities in the first place that give rise to mental emotional well-being. And how do we address the equity issues and the adverse community experience and the underlying issues that are upstream in the first place? And we want to address that from one end to the other. I loved the way that we began this morning with Linda, with her whole point being this morning, we need each other. We need each other more than ever. And I think that to begin with where Doris Kearns Goodwin had us, which is this is also no ordinary time, makes a conversation about partnership more important than ever. It's no ordinary time because while most of us in this room have been tracking these issues well and the increase of mental health and substance use issues in our country, the nation is awakening more than ever to what we are actually talking about. Not only are the numbers increasing, and we see it in our centers, on our streets, in our clinics, but the nation is waking to this issue. And it makes it a very, very important time for us to actually be able to seize that moment. Secondly, we all know now, and so does the country, that mental health and substance use disorder issues are now the leading cause of disability. It's causing healthcare systems like the one I'm working with and others to actually be able to awaken to that more fully. The community health needs assessments that healthcare providers do. I left my long-term colleagues at Kaiser Permanente just a few months ago to take this. We did 45 community health needs assessment. I think, Robin, helped me, inside Providence, about 50 community health needs assessments. Mental health was at the #1 or #2 in almost every single community health needs assessment in both of these great health systems that I've worked with, leading to a kind of a new thinking of healthcare providers about what are we going to do that has enough reach, intensity, and duration to really have a effective impact, rather than just sort of going, kind of a move from doing good things to being accountable. And that's really the shift that I think is in front of us right now. And while there is extraordinary uncertainty about what's happening, for example, the conversation in Washington, one thing is very certain, that if we're going to address effectively the array of mental health and substance use issues before us, particularly those equity, adverse child experience, adverse community experience, the toxic stress issues that are existing in our communities, we are going to have to fundamentally change the conversation and engage stakeholders and partners across a spectrum that we've never done before. And so it's a moment of extraordinary opportunity, and it plays right into this panel. As I think about why this panel, and I turn to introduce them in just a minute, my daughter is on my mind. I get to see her at the end of this week in DC. How many of you have kids? Yeah, how long does this go on, right? She's 24 and forever, right? So she knows that her dad has spent his life working to measurably improve the health of people in place. And the other day she came home with this report from the Institute of Medicine that said, after a century of increasing lifespan by 25 some years, that the children born today are, some will live 5 years less than their parents. And here's what she asked me: what have you been doing? Thank you, Eliza. Maybe that's the frame for us. What have we been doing? Particularly speaking to someone who's part of a sector, as many of you are, that is about 20% of the economy, investing in these kinds of outcomes. So with Eliza in mind, we've been really excited to build on the commitment of Providence St. Joseph Health to make, as was said, a $100 million investment in creating a new national foundation that would be a platform for other leading health systems, other philanthropies, and organizations such as yours to change the conversation and make tangible investments in what we're really viewing as a social movement approach. And what makes a social movement unique, because it's easy to talk about social movements, civil rights, and others, is distributed leadership. That we lead from where we stand. Yes, there are things we need to do together, but how do we essentially unleash the power that is resident in our communities and make really targeted investments, even as we unleash something broader? So as the Institute for Mental Health and Wellness sort of begins, and yes, we'll be able to make grants, we're also looking at social engagement and how do we change the conversation to norm discussing these issues? How do we impact policy? How do we build the research base so that between investments, clinical transformation, community transformation, policy change, communications, we essentially do an all-in strategy that can help take the country to the next level, and do that through partnership. And perhaps as significant as ever, that as we look at the move of the Affordable Care Act and the move from fee-for-service to at-risk arrangements or volume to value, healthcare organizations going at risk are going to need to partner with organizations like yours. And so we really want to unpack what can that look like, what are types of arrangements that will help that occur. The only other thing I want to mention before I introduce the panelists is for those of you that are interested, at 6 o'clock, we're going to do a Facebook Live after show. And so we're going to get into a dialogue, we'll get these folks started, and then we'll get into a dialogue. And if you have questions, we're going to take them here, but we also have a chance to continue the conversation Facebook Live at 6 afterwards. So feed the questions and we'll continue the dialogue. So the first question I want to ask, I want to ante up to as well, because I'd like it to be able to be provocative, which is to my fellow panelists, why do you do what you do? And I'll tell you why I do what I do. Because when I was 14, with a couple of other buddies in our rural Idaho community, we managed to get ourselves in a lot of trouble. On Mother's Day, actually. A lot of substances involved and vandalism. We were really in trouble. I mean, we were struggling. And we got caught. And when the community conversation came around of what do we do with these two 14-year-olds? 3 of them, really. The principal of the school said, any kids that would do this to this school and this community need this community. And they folded us back in. And they said, we're going to work with you. You stay here. You're ours. And he demonstrated the power of community to bring the other in and welcome me. And so I'm here because the power of community saved my life. Logan, my new friend, Chief Impact Officer at Trillium Family Services, a producer, musician, writer, and leader of our Facebook Live. Why do you do what you do?
Yeah. I'm historically a consumer of mental and behavioral health care services in my whole life. I'm a survivor of early childhood abuse, and I am also a public figure. You mentioned the music and the filmmaking and all of that. That started happening really young. I got signed when I was 17 years old and started playing shows and touring, and then eventually landed a job on MTV Payroll and had a show on Logo. And I also was really struggling all through that initial time. There were times where I was homeless. I had a 16-year addiction to cocaine, crack cocaine, and alcohol that had me in and out of housing and in and out of hospitals for about 16 years. And eventually, I met a doctor who asked me what had happened to me. And for whatever reason, no other doctors or rehab people had ever taken the time to do anything but treat my symptoms. And once I started really digging in with him, I realized that I could utilize my sort of music entertainment world. I was already talking to 26 million people every week. Why not talk about something that mattered to me instead of just how cool I am or whatever I was talking about before. So I started to really do that intentionally and marry the two worlds. And I was doing that publicly for years before I really had language for what it was. And eventually people from the outside came to me and said, we think you're a mental health advocate. We think you're doing the work that we're trying to do, and we also know that you're embedded in the communities we're trying to reach. And that sent me down a path towards this panel. You know, I founded the Keep Oregon Well campaign to fight stigma and discrimination in Oregon. We partner with celebrities, we partner with media, and we're reaching about 1.5 million people every week and have been for a couple of years.
Thank you, Logan. Beautiful sort of beginning and stage setting. To his left is Dr. Arpan Wagre. Arpan is a geriatric psychiatrist and oversees behavioral medicine at Swedish Health Services here in Seattle. Arpan, why do you do what you do?
So, I'm a part of the problem. I'm a part of the system that has created the problem, and I'm a part of the problem. And I feel that it is my moral responsibility to make meaningful difference. We've spent a lot of time admiring the broken mental health system, and now we actually want to start doing something about it. Think about it. If you have a patient in acute heart failure who comes into an emergency department seeking care, and you don't have resources to send them to the right place, you wouldn't strap them to a bed and leave them in an emergency room for 3 days. But that happens every single day in every part of the country with patients with mental health illness. And I've been watching this, and I haven't been able to change that yet, and that's why this matters to me. I want to make a difference.
Thank you so much. Beautiful frame. Robin Henderson, Robin is the Chief Executive of Behavioral Health at Providence Medical Group in Oregon, essentially leading behavioral health services across that state. Tell us, Robin, why do you do what you do?
Well, thank you, Tyler, and thanks to my colleague Arpan. I agree with him. I am part of the problem. I came from a family in a little town called Salem, Oregon, also known as the Gateway to Hell. My mother worked for those of you who know what this is, a community action agency. Back in the day, she was a grant writer, and my father was black, and so he was the token black guy on every governor's commission in Oregon, whether it was mental health, substance use, you name it. My dad was the token black guy, and my mom, of course, worked with all of these different commissions. So I grew up reading grants that my mother wrote about the structure and infrastructure of alcohol and drug, and this was how I learned how to proofread and other things. I don't know, I think she did it because I was probably ADD and was driving everybody nuts at that point, and they didn't have medication for that back in the 70s. But long story short, it's the only thing I've ever known other than playing jazz piano in a cocktail bar when I was in college and shortly thereafter for a while. Obviously was not quite a good enough piano player to make it on the circuit, so I went into mental health. And my very first position while I was still in college was at the state hospital. And I worked on the secure child and adolescent treatment unit. And I'll never forget one day when I was down there getting ready to go do a skills training group, there was a 3-year-old boy in the state hospital. He'd been born there. Had cerebral palsy and had a stroke at birth. And he was a mess. And somebody had given him milk duds, and he's just like covered in milk dud goo. And he's running around the unit, and he's just screaming. He runs up to me with these like slimy little hands, and he offers me this milk dud, which of course I took and palmed, and looked like I ate it. Oh, yum! Thank you, thank you, thank you. And he runs off, and the nurse sitting next to me says, "Isn't he just pathetic?" And I thought, wow, that's your frame of reference. We can do better, and we should do better. And I've spent a career working in facilities trying to make them better. I was, for a large period of my career, a turnaround artist. I would go into facilities that were really horrible and help turn them around and rebuild them. Until I went to Bend and got to build something from the ground up. And now I'm with Providence, getting to build something even better. So I'm here because I believe we can do this a lot better.
Thank you, Robin. To her right is Patrick Gordon. Patrick is the Associate Vice President of Rocky Mountain Health Plan, a payer, and leads an array of payment reform, health data exchange, and behavioral health services integration work in Colorado. Why do you do what you do, Patrick?
So talk about being part of the problem, right?
Hey.
Right? I've been doing this about 20 years now, and I don't share easily, but certainly can relate. I had a family with alcoholism, abuse, sexual abuse, all sorts of issues, and I saw over the years how my dearest loved ones struggled, continue to struggle, and frankly kind of fell behind. And my career is very fortunate. It's very fortunate to be successful in many ways, but working in this space, I would see things that would just fundamentally bother me, which is, we would work very hard, stay up all night, and then put a product out with a 40% increase on it. And people would say, good job, that was a really good job. And it doesn't take a rocket scientist to know that you can't continue to generate that type of product and have it produce anything. And so for me, I started what I think of as sort of a root cause search, which is what is behind all of this, and then you pick the rocks you want to bang your head into. That led me to root cause and root opportunity around primary care and behavioral health, social determinants, and fundamental inequities, and it led me 360 degrees where I think I started, looking for a way to close the gaps that I experienced in my own upbringing. And so there is a better way. It's not that difficult when you let go. That's the illusion of control. And the first step to getting control is letting go of it. There is such power available in community, and again, payers have a huge role to play in that. I'm very honored to be able to work in this space, and we do have to answer the question. I think about generations coming up behind us saying, what did you do? You know, how did you let things get to this point? Now's the time to do something.
Beautiful. So with that, we're going to dive in more to the conversation around partnership and sort of a leading payer who's helped transform payment in Colorado, a person who's designing care delivery systems in a state with a health plan, a leading clinician who's been providing care and actually helping think about its redesign, and someone who's described himself as a consumer and yet is changing the conversation and is every bit a prosumer of actually helping all of us find our voice. So Logan, I'd like to start with you, just to make it as tangible as possible. Again, the frame of partnership, thinking about what you've done and what you've built. Anyone who knows you knows you're a believer in the power of voice and expression and authenticity and truth. What is the power of narrative, of story, of voice in healing? And what are you seeing around partnership in creating a new conversation?
Sure. It's a big question with a lot of different answers. I can answer it from my perspective. What has the power of voice meant to me? I mean, I think early on, like I said, when I was struggling, I was saved by my own music. That was how I reached my feeling experience when I couldn't otherwise access it. And so telling my own personal narrative out was always a way of bringing myself in for whatever reason. And I think what I know to be true is that, a while back I had a therapist say to me, Logan, it doesn't have to be pretty to be true, but if it's true, it's beautiful. And I really latched onto that. I think all of my work in the world, all of my music, all of the filmmaking, all of the stuff we do with Keep Oregon Well, our Mental Health Matters, is all about finding that nugget of truth and then telling the story in a way that highlights the beauty of it. I think one real thing that has in my life been true is the power of coming out too, right? So when I was young, I was raised in a church environment that wasn't super affirming, and I also changed a lot of those people's minds by way of just standing up and saying, hey, I'm Logan, I'm gay, this is who I am, I'm still the same person that you knew before. And over the years, that really moved the people in my life into a place of understanding. And so I think of this Keep Oregon Well, Mental Health Matters movement as a coming out opportunity for people who are maybe in the field, for community, to provide a space for people like me who maybe aren't holding a megaphone that is reaching a bunch of people every week, to reach people. And I think also to be able to go beyond tolerance and acceptance into a place where we're really celebrating neurodiversity and highlighting that the difference, my being depressed, experiencing persistent suicidal ideation even to this day, is part of my magic. I'm successful, and you take this struggle away, you take the success away too.
One of the things I'm really appreciating already about what your story is that rather than just, it's kind of thinking about from a partnership perspective, you actually have built partnership around the healing process and through people's healing stories. Yeah. So the very individuals that we're often talking about become part of the transformation themselves, and you've built a platform for that.
Yeah, I think that applies to clients. That I'm Chief Impact Officer at Trillium Family Services. It's Oregon's largest provider of mental and behavioral health care for children and families. They're the stewards of the Keep Oregon Well campaign, and so being able to highlight the really truly triumphant stories of the youth that we serve, or the families we reach, or the really difficult work that happens within those facilities, and tell those stories in a way that feels celebratory, like I said, has been really cool. And that's all intermixed with me interviewing Kevin Bacon about his history of mental illness in his family, and me talking to Charlie XCX with a room full of 14-year-olds that idolize her. Some of those things have been really powerful on the internet, and then to be able to flatten that sort of power differential between celebrities and regular people, and highlight people's stories as the celebrity has been really cool to watch.
A shared humanity,
For sure.
regardless of how well known we might be. Arpan, it's been so great getting to know you over these last few months. Some of the highest suffering and highest cost patients in Medicaid are pregnant moms. And I understand your work with Swedish has created an innovative approach that you might want to, might ask you to go into a little bit in terms of partnership, but also what we might learn about it around how you're building partnership across an integrated full spectrum of care.
So that's a great question. And so postpartum depression is the most common complication of childbearing. It has significant impact on the mother and the baby when untreated. Yet it's so hard to find care. We've not designed care models that revolve around the service user or their families. It's always around the clinicians and the services that we can offer. So we really redesigned our approach towards this and just took a very different, broad, full spectrum approach and started looking at this differently. It started off with a lot of education in OB clinics, including depression screening into pregnancy pathways, postpartum screening pathways. We then hired social workers into OB clinics to work with psychiatrists. And what was really important is that when somebody is diagnosed with a condition with anxiety or depression, you have to help them get the care that they want. I mean, accounting for the patient preference. So some people want mindfulness programs, they want wellness, they want yoga, they want, whatever it might be. So being able to partner with our community, leaders in these areas, we help, transition them. And for people then who need more intensive therapy, interpersonal therapy, cognitive behavioral therapy, they get it in the convenience of the OB clinic, trying to destigmatize that. And when focusing on the full spectrum, sometimes people might need a comprehensive psychiatric assessment. They might need to have a discussion about, what the impact of these medications are going to be on the unborn baby or during breastfeeding, and then also what is the impact of an untreated illness, on pregnancy. And so focusing on all of this and having psychiatrists available in these clinics, but then understanding that there might be people who have greater care needs. So all the way to getting people admitted to inpatient psychiatric units when they need that, providing brain stimulation treatment when needed. But then we started doing this and we realized that there's another group that we needed to help. There are a lot of moms who, in the first month postpartum, were getting very depressed and functionally disabled. They're not suicidal, not homicidal, but could not function, and they needed an intensive level of care. And so, there was a fear that they didn't want to, disrupt their breastfeeding. They didn't want to disrupt the bonding with their baby. So we created a day hospital program where moms can bring in babies and have intensive therapy right there. So this is one part of it. And again, engaging with the community partners. So whenever there's a case manager involved, we're working with them right from the very beginning. And then another part of it is chemical abuse. So we have a program for pregnant women abusing any drugs, and we would admit them at any trimester of their pregnancy, any time, and they first go through, this is the only program in the state of Washington, and so admit them for medical stabilization, detox, and then go through an intensive treatment program. But again, with that focus on the whole person and the ability to transition them to the next level of care. So this has been something that's very dear to our heart, and we've focused a lot on this work.
Thank you. Building on the partnership that you were describing, sort of at each stage of that community partners, I'm going to, Robin, turn to you. I mean, just taking Oregon, Providence is the leading provider of behavioral health services. It's a large system. There's so many things it can do. Why do you need partners? We're talking to mostly community-based organizations. Why does a Providence, and not only in your case, but why should we start thinking these big health systems that are doing all this need partnership in the new environment?
The first time that I came to the national conference a few years ago, we were in Vegas, and I was doing a day-long conference with Dale Jarvis, my friend Dale Jarvis, and when he introduced me for the first time, he said, and this is my co-presenter, Robin Henderson, she's from the dark side. Because I was working at that time for a health system, and again, I'm working with a health system now, and we are often seen as the 1,000-pound gorilla. That's who we are in a community. And so people, when I come in and say, oh yes, I'm with Providence, it's like, the first fear is, oh my gosh, you're going to start providing the services that I provide. And the reality is, I can't do it all, and we shouldn't do it all. What we need to do, however, is to help our community partners change the way that they're able to be reimbursed for their services so that they can be part of where our move from volume to value goes. Most community providers at this point are still in segmented portions of providing care in a widget-based environment. And by widget-based, meaning, you eat what you kill, basically. And yet health systems are thinking in a population health manner of, we've got to be able to get out there and meet people where they are. And guess what? Where they shouldn't be is in my hospital. Where they should be is as close to their community as they can possibly be. And those services can't be often provided by me, but can be supported by me as a health system. So for me, I look at this as, when I'm in Portland, there's a lot of services we provide, inpatient, partial, all those other good things, but we don't provide specialty outpatient services. We have a wonderful, vast array of community providers who do so, that we contract with and support in a variety of different ways. But we have to go a step further and figure out how we bring them from volume into value so that they can be part of what I call the first dollar of healthcare as opposed to the fifth or sixth. So for me, I really see this as, we need to be part of the fabric of the community, and that means we need to be better partners and not just always the providers.
Great. Well, I'm sure that there's probably room to go around when it's the dark side, right? And Patrick, I'm sure sometimes you are seen in that light, or the sector. Yeah. But as a payer, you're in an extraordinary position to influence how care is provided and paid for in the communities where you have members. What are some of the innovative programs that you've helped see occur, and tell us a little bit about partnership in those?
Well, some of the most exciting programs are the simplest, from my perspective, and the lowest cost. They often revolve around basic prevention, primary care, and behavioral health, but you can build quite a population health intervention on top of that foundation. The interesting part of that, though, is not this or that program, but the process that we have to go through to get to those very simple changes. And again, I think what you mentioned earlier, Tyler, is the idea of accountability and also diffuse leadership. In our case, we actually have that concept and work to practice it every day, where we accept accountability. The single point of accountability, in many ways, is the payer and its contract with the state, the government, employers, whatever. But rather than attempting to control, we have to participate in a model with diffuse authority, meaning that we let go of data, we share data, we let go of the design process and participate in it, we let go of decision making and help to get to better decisions in the process of doing that. And again, those are the harder changes. It's not the dollars. It's breaking free of that construct. And I think that the opportunity is, again, thinking of the health system, that we often point fingers at the health system and vice versa at the payer. To the extent we get off of our platforms and recognize the power of networks, recognize the resilience and the adaptability and the fact that networks build capacity and can grow, and that we will never get there trying to pave our own road or build our own world. That's the shift. And I think that increasingly, there's a recognition, particularly as people try to get upstreams, of the real drivers of these trends in our society. But it's not an easy one. Like everything else, it's a matter of culture, practice, and incremental change.
Yeah. So we're really starting to reframe the role of health systems actually as buyers of what our community partners are producing, if we can sort of think a little bit about some really different language. And Arpan, if I could sort of build with Patrick on, he's saying we need to change our thinking, we need to change our platforms. How does that tie to this full spectrum integration that you've been describing? Link that a little bit for us.
So I think I completely agree with the way Patrick described this. We need to fundamentally change our care design model. So I'm thinking about this very simplistically. So you have full spectrum integration, starting off with primary care, but meeting the patient, making sure that there's no wrong door for care. Wherever they present, being able to deliver the care to them at that point. And I'm thinking of another aspect of this, which is technology. So behavioral health is a highly cognitive discipline, so it naturally lends itself to telemedicine. Now, what's really important, though, is that we need to think about this differently. We need to think about leveraging technology to deliver newer models of care, more effective models of care that are not completely dependent on that, fee-for-service reimbursement way. So models like Project Echo, you break the silos between primary care and specialty care. You're able to disseminate medical knowledge, translate it into daily practice, and serve medical, communities that are underserved. So that e-consultation, being able to have joint visits with primary care physicians in their offices using technology, being able to deliver in-home therapy, and then, being able to meet people, say, in an acute psychiatric crisis in a rural hospital, being able to have a telepsychiatric consultation where you help alleviate suffering, you help treat them right there. So thinking about the full spectrum, thinking about every place where the patient might present to get care, and designing the care around the service user experience, around their families, the carer's experience, and changing our approach towards that is going to be critical.
Yeah. So I'm going to come back to Patrick to sort of build on this a little bit, and then we'll talk a little bit about this Oregon partnership and then open the floor. So start thinking about your questions a little bit. Patrick, I'm thinking about what Arpan just said. So many of those services, for a lot of providers, more cost, more expenditure. How do we do all of that? And yet you've been really pioneering from a total cost of care perspective, another way. There's thinking about a network that actually allows that kind, what Arpan's describing, to really be actually paid for and actually facilitate the kind of partnerships we're trying to describe here. Can you tell us a little bit about how you've done that, how you've modeled that?
Yeah, sometimes you just kind of stumble into it, right? The reality is that when you make the shift from talking about the patient being at the center to actually following the patient and thinking about how to get things to the patient rather than how to get the patient to you or to some part of the system, the thinking changes. And you look well outside the walls of traditional clinical settings, systems boundaries, payer catchments. Then you start looking well outside the boundaries of healthcare altogether. And in our case, the opportunity is that rather than trying to, again, build everything ourselves, assess or test or predict our way bit by bit with the part of the data that we control or we have access to, by partnering more effectively, you get access to a wealth of data. Those assessments populate themselves. Those predictive models become much, much more powerful, and then the opportunities open up. And so, in many cases, just a little bit of data, sometimes not at the big data level, but at the little data level. Building a network, building tributaries of information about a patient, and putting the patient in a position to actually access a network that is responsive, not brittle and bureaucratic, is the key. So that means local partnerships, invariably. You can't do this from the top down, you can't phone it in, you can't dial it in. You've got to have feet on the street, you've got to have local community partnerships, you've got to authentically invest in community. That's a totally different, that's not community benefit.
That's right.
That's community leadership.
Yes, beautiful, beautifully described. In the center here, you two have actually partnered quite a lot in Oregon, between Providence and Trillium Family Services and Keep Oregon Well, and so much of what you've done. Either of you start. What's been the key to your partnership? Not only what you've done, but what's really caused this to persist all the way through this particular time, where economic challenges and the rest?
I'm happy to start. I call what you're describing radical community engagement. I think that's our model. It's so far out of the box, we reject the box, and have realized that most of the community's not in that box, right? And so we've gone out to concerts, we've gone out to schools, we've gone out to wherever community is. Kim Scott, who's the CEO of Trillium Family Services, gave me one directive when I started building this advocacy platform, and it was act within community and not upon community. And so we do that every step of the way. Part of that, what keeps us apart is this idea that we're in competition, right? And I know in Oregon at any given time, just talking about children, there's 139,000 plus children who are experiencing some sort of mental health struggle or crisis. And if we all put all of our beds, all of our residential services together, we will never meet the need. And so that idea that we're in competition, I think we acknowledge that's false. And it's on us to kind of break those barriers down. One way we've done that initially when I started was the Keep Oregon Well Mental Health Heroes Awards, which was just about picking out the different people in the history of Oregon's mental and behavioral health care field who have helped pave the way for it to thrive. And so that, I think, right off the bat when we launched the campaign, that was really important to come out swinging with acceptance and acknowledging that we, even though we were the steward organization, we weren't the Borg or the big gorilla or whatever you want to call it. We really were there to highlight the good work and stories of other people.
And it was a very interesting set of circumstances that brought us together in a little bit tighter partnership along the way. We've worked with Trillium as a provider. We have an inpatient child psychiatric unit and adolescent psychiatric unit, and their provision of residential services is really key to moving kids throughout the system. But the entire system in Oregon backed up. About 6-8 months ago, we began to notice that nothing really was moving, and yet at times, Trillium would have empty beds, or we would have empty beds, or Albertina Kerr, or some of the other providers would have empty beds, but there was no mechanism for us to share that information amongst each other and get the right child into the right type of bed at the right time. What would happen were crazy machinations of, if you're on a waiting list for this type of a bed, well, the way you skip the waiting list is to go to the ER, where there happens to be a psychiatric unit, because if you can get admitted to the ER, then you can jump the wait list for another type of bed. And this kind of crazy stuff really hurts the children that we're trying to serve. So we really got to talking about our mission. And what was our mission as Providence, and Trillium's mission as not only Trillium Family Services, but Trillium as an advocacy organization. And at the time, Trillium as an advocacy organization and the Keep Oregon Well campaign really started to have some synergistic types of relationships with Providence Institute for Mental Health and Wellness, and how we really wanted to bring about how you could change the conversation from the very beginning with the people that were basically serving the children and families of Oregon. So it's been a very interesting partnership along the way that we're still kind of fumbling our way through, but we realized something very important. We could do a lot more together than we could apart. And for Trillium, as a child serving agency in Oregon, they are limited to one bucket of dollars. But as Providence, we're limited not only to all of the dollars we see as the health system and primary care and all those other dollars, but the 600,000 lives we have covered on a health plan. And if we didn't figure out how to care for and support one of the most necessary and needed specialty areas, we might not have that available to the 600,000 covered lives we were responsible for, aside from the rest of the people of Oregon. So that's what really drove that continuing conversation, and still drives that conversation today between what Providence and Trillium can do better together than we could apart.
Yeah. I think we're also just really committed to the good work we do being the best, and also have acknowledged that all of us doing really good work and then opening our doors and sending families and children and patients back out into community just to get immediately re-injured sort of necessitates us also building a trauma-informed community as part of that ecosystem, so that community is one of the main partners in everything we build, everything we do, every word I say. It's that sort of nothing about us without us.
And I really want to touch on it. That's one of the biggest reasons Providence was attracted to Trillium, was their commitment to trauma-informed care. We recognize that every time someone comes into our ER, it's a traumatizing experience. It really is. An ER is not the place to have a mental health crisis, and it's certainly not the place to have a mental health crisis for 3, 4, 5, 7 days. It's a very traumatizing place, not only for the people that we're serving, but also for the people who work there. This is not what they went to school for, to learn how to do in an emergency department, right? So having that commitment to trauma-informed care is something that we get to learn from Trillium every day.
So I'm going to turn to us. Our objective all along was to have at least 15 minutes for open floor, and so we have it. Is there anything you want to say to each other, or should we just open? Anybody have something you'd like to ask the group? My good friend Ron Bialik, please.
Thank you. This is an incredible discussion. Thank you so much for sharing what you're doing.
to jump in. I agree with you 110%. There's some friends who know me from Oregon High out there who know that the drum that I beat is I don't want to build any more acute care beds ever. I don't want to build another single acute care bed ever. I would love to plow more money into housing. Providence made a huge joint commitment along with other major health systems in Oregon to a $120 million fund to build a significantly large portion of supported housing in downtown Portland. But broader than that, we're becoming involved in conversations with school districts. The Gladstone School District in Oregon, a little school district just outside of West Lynn where I live, has made a commitment to ACEs and to teaching their administrators, their students, their families, their teachers about the impact of adverse childhood events. And Providence supports that not only with funding, but with actual people to go in there and to pilot how we can make sure that no child ever gets kicked out of that school district again. Because we know those red zone children are the children who are going to end up on the streets and in our hospitals as adults. We have to find those little nuggets. We can't stand it all up today, but we've got to find those little nuggets and pull those things together because that's really the long play. I agree with you completely.
I would just add to what Robin is saying. Part of what I do is build emergent telepsychiatry networks for emergency departments across our 7-state region. And every time we provide psychiatric services in an emergency room, I think we failed. What we should have done is meet people upstream and help them before they get to that crisis. So you're absolutely right.
And again, the only thing I would add with respect to housing is everybody knows it's hyper-local. So there's no one big easy push when it comes to housing. There are structural and big ticket policy issues to address, but to really impact housing, you've got to organize yourself to work at an incredibly local level. And big organizations don't do that well. They like things to be easy. They like things to happen from the top down. And you know, with respect to housing, we're not going to get there quickly unless we learn to work a different way.
I might just add to that, our healthcare sector is 18% of the economy, typically the largest employer, largest enterprises in our communities. I think providers are increasingly understanding their role as anchor institutions also, with extraordinary hiring capability. Their living wage jobs and payroll, we're not just hiring anybody, but actually hiring local, starts to play into not only the community determinants of mental health, but the community determinants of health overall. So how we use increasingly our hiring ability, our purchasing ability. I know at Kaiser Permanente, our purchasing was 10 times our community benefit. Our localizing purchasing, buying local, starts to spin that economic flywheel that's part of actually creating healthier communities in the first place. Not to mentioning leveraging our investment portfolios or pension funds to build housing. So I think part of what you can be part of is helping create a new economy that's helping drive the local economy by using healthcare to invest equitably in a more healthy, equitable community to start with. And I think that's what you're pointing to. Other questions, comments? What can you interested in terms of, yes, please, right here in front.
I was just wondering, thank you for...
Would you mind standing, just so that I want to make sure folks in the room can hear you too, sir?
So I just was wondering, I'm from Ohio, Cincinnati, and I was just wondering if you're having problems with opiates in this part of the country. I thought you might say that. I was curious, since we're witnessing that the port of entry is into our emergency rooms, and then trying to transform that care at that point is, there's a good conversation going on in the greater Cincinnati area about that, but there's a lot of work to do. And so I was wondering, when you're talking about integrating, mental health illnesses, the disease of addiction, especially in dealing with opiates, what are you doing here? And what would you, if you had a magic wand, what would you do first, and what barriers would you have to eliminate?
So yes, it's a big problem over here as well, and I think that's an excellent question. There are multiple things we're trying to do. I'm not suggesting that we have the answer. We're learning, and I think one of our philosophies is that none of us are going to live long enough to only learn from our mistakes. So we're going to quickly learn from others as well. And so We have worked towards creating oxy-free EDs, so that's been a big push, and there's some of them that are very successful. We actually did the first probably about 8 years ago, right here in Seattle. What's interesting is, you know, we are the cause of this problem to a great extent. So surgeon, you know, after surgery and after various things, Tyler actually had organized a call for us with the chief of perioperative services at Providence St. Joseph, and we're working towards creating care pathways earlier on to actually talk about pain management before surgery and before various medical interventions, and trying to get upstream over there. We've worked towards creating opioid care pathways that are standardized across our 7 states, across all primary care, and so a lot of different things along those lines. We still don't have the magic bullet, but like every little step is important.
I think the only thing that I'd add into that, one of the best tools we've had in Oregon, and you have this in Washington as well, is a tool called the ED Information Exchange. And it's an emergency department information exchange that basically connects all of the emergency departments in Oregon and Washington in a way that we can put a care plan on somebody's records, so that if they have an issue with opioids or something like that, or they have a chronic pain contract that limits what type of medication they can get, any ER can see that. When they come and present in the ER, it's flagged and it pops up for them. What we started to do was to realize that was really great, but there was a small portion of people that we call the ultra super high utilizing population. And we targeted in on 50 of those individuals, many of whom had extreme opiate addiction, along with homelessness and other types of very disabling conditions. These people, 50 individuals, had more than 2,200 ER visits in a year within the greater Portland area. And we went after those folks, regardless of their payer. All of them, nearly all of them, have Medicaid or Medicare insurance. Very few were uninsured. And found that it really took going in and having one individual go in and work with them right there where they were, under a bridge, wherever it was that they were, and helping them see that just one more time, treatment may work for them. We were very, very grateful to see that nearly 30% of the folks that we intervened, which doesn't sound like a large number, but you're talking about super utilizers. We were able to get connected and actually committed and in for those first and second visits to start that journey to move forward. We're only 2 months out of the program, still following these individuals and working with them. But we're finding it's those types of catching people and meeting them where they are that's being the most effective for us. It's hard work.
Yeah, the only thing I could add is, again, just a quick note on the information exchange, hugely powerful. And we have access to a similar resource in Colorado, and it's incredibly useful, because you can't build your opioid protocol, your pain protocol, or your community protocol unless you can take advantage of the patient, the client, the person in that moment. And so real-time information is hugely powerful. But again, all I would say is that when it comes to opioid, it is perhaps the single greatest public health issue of our time. We need a comprehensive local strategy. It begins with awareness. It begins with community organization. And so often what we see is kind of pinpricks or efforts to push on a balloon. We all can do a much better job of community organizing around the issue, because it really does, I think, take a comprehensive, sustained, long-term kind of public health push to make a difference.
I'll jump in just a little bit about that piece specifically. How do you reach community? We've been doing a lot of messaging, not just about opioids or different seasonal affective disorders. All the time we're on the radio, so we've partnered with different people like Jay Moore, the comedian, or iHeartMedia, so we're on all of their channels, KGW, NBC News, Alpha Media, Kink FM, so all of literally any station you turn on the radio or any TV station, we're on there with these spokespeople talking about this sort of stuff. And so I think it's both, right? If we keep changing our policies without changing hearts and minds out there, without sort of chipping away at the judgment that comes with somebody standing up and saying, hey, I'm struggling with this, then we've missed the boat. We have to do both. Yeah.
I appreciated this last cycle of how it moved from right inside the heart of clinical care and increasingly towards the partnership with communities, the only way to really tackle this at the end of the day. Please, here, if you stand, yes.
I was just going to say, as far as from mental
Please.
So thank you all very much. Appreciate you being here. It's been very informative. I know one of the things that I hear when dealing with some of the larger community-based providers are the ones who, kind of the social workers are maybe off in their own group or something. There is some fear, right, that as you build these giant communities of care, that there's no longer going to be the shingle provider, similar to how the primary care is dealt with, some of the changes with the ACO models, and we did see kind of a shift where they used to be in business for themselves, and now a lot of them are employed. And so, what are your thoughts about that? If you're a social worker out there hearing this change, and it looks like a bunch of big people sitting around in a table making decisions about what healthcare looks like. If you're that individual social worker, how do you help them? How do you address their concern that maybe I'm not practicing anymore for myself?
I had the opportunity a couple of weeks ago to meet with the CMO of our health plan, and we were talking about the network in Oregon and what the network looked like and how the network worked. And he said to me, why aren't you building up the outpatient space? Why don't you do that? That's something that, it's going to be easier for us to contract if we can just contract with you and you'll be a big group. And I said, that's exactly what you don't want me to do. Because part of what makes this space work in outpatient is the choice of provider and the fact that there are a lot of really, really excellent individual practitioners out there, sold shingles. What we have to figure out how to do as a network is how do we connect those people and make it easier for them to communicate with us? Because right now we set a lot of barriers in play. I've got Epic, nobody wants that, and I don't make it very easy for you to interface with me. We have to figure out how we remove those barriers so that we can keep a thriving private practice community, and we also have to figure out how do we help private providers get to that first dollar? How do we reward them for taking call? How do we reward them for keeping their patients out of the ER? How do we set quality incentive metrics that private providers could access and get a bonus at the end of the year for keeping our patients out of the hospital? And those are the things that I turned back to my CMO and said, this is what I want to work on as we look at building out a different network. Because we have to change how we engage with that community in order for the community to be able to engage with us. I'm a big believer in the private provider community. I'm a psychologist by training, was a private provider once myself. But I don't think that it's our role to go in and take the soul out of that.
Patrick?
I'm sorry.
Well, and again, it's network, not platform. You're not going to pave over the community with Epic. In the health plan, it's the same thing. There's a huge value proposition for the small community service provider organizations who could take advantage of tools and resources that we could bring, and they're excited to have a seat at the healthcare table. But we've got to adapt, and we've got to be flexible, and that means working outside of our comfort zone. Also means working across the community, not just with our own members or with our own products and partners, but really in kind of a multi-tenant, open, and comprehensive population-based manner.
All I was going to say was that we can't do it alone, and I don't think we can do it without you. And so it's really about how do we align our incentives and do this right.
Maybe I think we are at time, so so maybe just one last question, and each of you think of a sentence or two. And I'd just like to really ask sort of what advice do you have for community-based partners to be positioning themselves? Robin, you described some things that as providers or as large health systems we need to be doing and as payers. What counsel would you give community agencies, community partners, community providers, individual or organizations to be ready to participate more fully in these new networks?
I would say play to your strengths. Know what it is that you do well, hone it, do it really, really well, and then tell me about it. What is the sweet spot your agency has? Everybody has one, whether it's I'm really good with eating disorder patients, I'm really good with these types of adolescents, and here's the value proposition I bring to the table. Don't assume that I know that, and bring what it is that is your strength, rather than creating what you think I might need.
Yeah, oh, I'm sorry.
Please, go ahead, Patrick,
Okay.
please.
So often, providers or smaller organizations ask, well, what are the magic words I say? What accreditation, what recognition, what boxes do I have to check so that I can get access to these types of relationships? And the reality is that none of those matter. They're not irrelevant, but they're incidental to something. They're incidental to what Robin just described, which is know what you're good at and have a vision. And understand where you can make a contribution and understand where you can receive. Those leaders that are able to communicate with us in those terms oftentimes end up with much greater access to resources than others who, again, try to sort of get the magic accreditation or the magic suite of programs together. And again, that's incidental to the bigger cause.
Along the same lines, I was just going to echo that and say that try to, make your voice heard. Try to make sure that you have a seat at every table, because if you're not on the table, then you're probably going to be on the menu. So we need to make sure that we're
Yeah, and I would just say that oftentimes I think the call's coming from inside the house. It's that old horror movie adage. If stigma exists in organizations, it's going to be passed on to community. I think if you're trying to reach community, if you're trying to reach youth, pay attention. It's actually not rocket science. Go where they're at. If they're at sports games, pay attention to who they listen to. Meet them there. And I guess the last thing I would say is just this idea that we are coming in to empower communities is false. Communities are empowered already. They know what they need. They know how to reach them, and it's on us to build relationship.
I want to turf on one brief thing that Logan said that I think is so very, very important. We as providers are often the purveyors of stigma. If you think about it, what do we say? We look at people and say, come into my office, no one will know you're here. I'll keep your information confidential, won't talk about it, won't share it with anybody. There's a private back door, you can go out. We have to change that frame as providers of mental health services and open this up and normalize it. The best interaction I had last week over spring break when my kids were here was when I picked up the 16-year-old kid who was coming to spend the week with us, and he said, hey, I went to the doctor, and I've got seasonal affective disorder. Just like he would say, hey, I sprained my ankle playing soccer last week. It's programs like what Logan's doing with Keep Oregon Well that make it possible for my kids and their friends to have open conversations without shame, without stigma, and without the type of guilt that was around in my generation. So thank you.
And thank each of you in a time when I think across the country there's a sense of a little loss of hope, and we're talking about deaths of despair and all. What you all are doing in our communities, what you're talking about in terms of partnership, are rays of light in the nation. And so thank you for the work you do. Patrick, Robin, Logan, Arpan, thank you. And thank you for the National Conference. And if you have any questions or things you think we ought to be talking about in the follow-up, please write us a note and we'll continue the conversation at 6, Facebook Live.